Hello and welcome back to Straumann Live from the Arena of Confidence at IDS. My name is Dr. Artemis Atkins and I have the pleasure of welcoming Professor Daniel Rothamel to the program today. He is head of Department of Oral Maxillofacial Plastic Surgery at the Johanniter Hospital, Bethesda, Mönchengladbach, and associate professor of Heinrich Heine University in Düsseldorf, Germany. Has a strong interest in biomaterials research with more than 100 international peer-reviewed articles published, has researched biomaterials for many years with a focus on collagen-based membranes. I would like to welcome you, Professor Rothamel, to the program. Thank you for joining us.
Thank you very much for the invitation.
Absolutely. So this year we celebrate the 10th anniversary of the JSON membrane. And I wanted to kind of get some experience, if you don't mind sharing your background with regards to collagen membranes in particular for the last 15 or so years, where you've seen them go.
Thank you very much. I'm working in the field of collagen membranes and biomaterials for about 15 to 17 years now. And I'm really happy that a lot of things have been changed within this long period. First of all, in the beginning, about 15 years ago, there was still some discussion whether we need a membrane to separate the bone substitute material from the surrounding soft tissue. So a lot of clinicians thought that the periosteum is the best membrane and there's enough barrier function when we just place the membrane, place the periosteum on the graft. Today we know that you can be successful, but when we look at high number of patients, at high number of augmentations, there's a significant advantage of using membrane, whatever origin, to separate bone substitute materials from the surrounding soft tissue. So there's now scientific evidence to get better results when applying bone substitute materials using membranes.
Very good. Thank you so much. What about, what's in your view the ideal collagen membrane?
The ideal collagen membrane might be a membrane that is based on different properties that are ideal for a biomaterial that is used for the separation to the surrounding soft tissue. So first of all, we need a good biocompatibility. Biocompatibility means that we don't want to have an inflammatory response to the membrane just because we installed it into the human body, meaning that we have to have a good tissue integration too, that there's no split around the membrane, that we have no inflammatory response, no attraction of multinucleated giant cells, and that the membrane is biodegraded on a more enzymatic way than on an inflammatory way.
Okay.
Then the second aspect is, of course, barrier function. When we think about the idea of GBR procedures, the most important aspect for sure is the situation that we want to separate the graft from the soft tissue. So in the first generation, there were non-absorbable membranes, and these non-absorbable membranes had a 100% occlusion of the graft. So after that, there were some studies indicating that little perforations might be even useful for the invasion of blood vessels, for example. Then we had to realize that when using an absorbable membrane, it's not that important to have this completely extended barrier function, that the initial phase of the bone formation is determining the direction the tissue will develop. So we have the ideal material that is also supporting the exclusion of the soft tissue cells, but also allowing for blood vessel ingrowth. We're focused on this in several studies about the angiogenetic aspects of collagen membranes, because we know that...
Did you say angiogenetic?
Angiogenetic
Genetic aspects,
yes.
Okay,
and
I'm sorry.
Because we saw that compared to other absorbed membranes like polylactide membranes, for example, polyglycolide membranes or copolymer membranes, that this is a big advantage of using a collagen membrane, that blood vessels are easy invading into the membrane body and also bringing some nutrition transfer to the underlying grafts. In most of the cases, we have the periosteum on top.
Right.
of the graft. And using a non-absorbent membrane will exclude also the positive effects of this periosteum. So when we use a collagen membrane that allows for blood vessel ingrowth after a time that has to be defined, of course, then we also get the positive effect of the periosteum, which may also increase the quality of the graft. Then the third aspect is for sure that we need an ease of clinical handling.
Right.
So when we have a membrane, we want to tag it, we want to pin it, we want to use it in dry and wet conditions. So this is one thing that is very important for the clinician, that the clinician is able to easily use this membrane and to focus on different aspects. The first aspect, of course, is barrier function.
Right.
But also, there's another important aspect that is important to immobilize the graft. And when we have a membrane that is able to be tacked or being sutured, then this facilitates the handling properties and the ideal application of the membrane.
Very good.
Last but
Thank
not
you so
least,
much. Yeah.
an ideal membrane would be maintaining the space too, which is not the case when we talk about collagen membranes. That's the big drawback of using collagen membranes. We know this from titanium reinforced EPDFE membranes, that you can use it even without bone substitute material underneath. And when we're using it, just the stabilization of the blood clot might lead to quite nice bone formation.
Very nice.
With collagen membranes, and this is the case for all the collagen membranes that are available in the market, they tend to collapse into the defect area.
Right, which is a handling issue. Exactly.
But it's not a big disadvantage of these membranes, because everybody would use these kinds of membranes with additional use of bone substitute materials.
Exactly.
So the stability and the volume maintenance is coming from the bone substitute material and not from the membrane itself. So in situations where we have a larger graft, it's also nice to use some additional autogenous bone, but when we use a volume stable bone substitute material like Cerebone, for example, there's no need for maintaining the volume based on the properties of the membrane.
Very
So
good.
this would be the ideal membrane. Of
ideal
course, it's quite
collagen
hard to fulfill all the requirements,
Right.
no doubt about this, but with a JASA membrane, we might have found something that is quite acceptable and delivering reliable
Fulfills
results.
This, yes, on this promise. Very nice. I'm curious, do you remember your first case with the Jason membrane?
So the first case I performed with the JASA membrane was a quite demanding case, actually. I know this case quite well because I had to postpone this patient two times because the registration of the membrane took some time. So the situation was that the founders of Botis that invented the JASON membrane were working on this project for several years before even thinking about founding the company. And I was part of the development team of the JASON membrane, and we could specifically influence the development of this membrane. They had some bone substitute materials already because it was a company that was providing artificial hip joints and also bone substitute materials. And when I first got the bone substitute material, which was 3.5 millimeters size, acceptable for the sinus but not for lateral augmentations, we found that this material is delivering quite nice results in terms of bone formation. Nevertheless, if you have a nice bone substitute material, it's not enough. So the idea was to also develop a membrane that fits perfectly to this long-lasting Cerebone material, and at the end we had this JASON membrane developed from the scientific aspect, but it took a long time until it was available for the market and that the registration was done. So this patient had a large defect in the upper front. We planned to install 3 implants, and there was one defect that was inside the ridge contour, which can be easily treated with other membranes for sure, but there was a large defect exactly in the upper front where we had to go outside the ridge contour. And the patient was asking for single stage surgery that we installed the implant and did the grafting at the same time.
Gotcha.
So we thought that for this indication, we will wait for this Jason membrane, and
Right.
because of the registration that takes a long time in Germany, especially, the patient was very patient.
Was it worth the wait?
It was worth the waiting.
I'm so glad.
And we did this operation directly after the registration. I think I got the information that the registration was done on a Friday, and we did this operation on a Tuesday. And we did a large graft with the cerebone and an autogenous bone that was harvested in progress of implant bed preparation. We did a lot of periosteum slitting and this single layer of Jason membrane on top of it.
Very
And
nice.
after 4 months of healing, I did the re-entry, the uncovering of the implants.
Yes.
And I was quite surprised. There was something I didn't see before, that there were still clearly visible some remnants of the membrane.
Uh-huh.
So indicating that the absorption
Very
time
nice,
of the
yeah.
membrane might be something between 3 and 4 months maybe.
Right.
And also the bone underneath was beautiful, was perfect.
integrated,
There was
yeah,
bone
very nice.
formation to the outline of the graft. Also something that I was not used to when I used bone substitute materials in combination with collagen membranes. We didn't see the patient for several years afterwards, but just 2 years ago, he just came back because of a problem of the lower jaw.
Yeah.
And there we were able to re-evaluate the
Re-evaluate.
final result,
Very
and
nice.
we were still quite impressed about the long-lasting,
stability.
excellent result we got with this
Very
combination.
nice. So now I'm a dentist out there, and I want to know, why Jason membrane? How does the Jason membrane differ from all other collagen membranes? Why choose this one?
So first of all, the Jason membrane is a very long-lasting membrane. There are different membranes available on the market, but most of the long-lasting membranes are gaining their long barrier function based on some chemical cross-linking, for example. We did a lot of research about 12 years ago about different kinds of stabilization of collagen, like chemical cross-linking, sugar insertion into the molecules. And what we found was all the different cross-linking techniques are also changing the biocompatibility, the tissue integration, which may compromise the clinical outcome. So with a Jason membrane, we have a membrane that is just based on the idea to maintain a native tissue, the pericardium, with no artificial cross-linking. There are some cross-linking, natural cross-linking areas in every collagen structure,
Right.
but it's not artificially enhanced. And the barrier function is just based on a very specific morphological structure. So usually with other collagen membranes, they're either natural membranes, which means that we have a lot of individual collagen strains that are not providing long barrier function, or they're coming from Achilles tendon, for example, and then the collagen structure is completely destroyed and reorganized. So that this is not a native structure. And in combination with cross-linking, we see that there are more problems when it comes to normal healing, wound descents, and also clinical outcome when we do this artificial cross-linking.
Gotcha.
So the idea was that this pericardium will maintain a long barrier function itself. And this is, of course, the biggest advantage of using the Jason membrane.
Right.
Moreover, it's a very thin membrane. So especially in cases where we have thin gingiva biotype, for example, it's not hard to close the site. There are double layer techniques described in the literature. Of course, we can apply 2 layers of membranes, but then we need to release the flap even more. We need to perform more invasive surgery that might be not necessary when we use a very thin membrane.
Right.
Also, this we need to take into account.
You mentioned the thin membrane. I'm actually interested in getting your perspective on the handling of this very thin Jason membrane. How does it handle for you clinically?
So the handling of the membrane is quite nice in both dry and wet conditions. I'm using this membrane in larger and in smaller augmentation areas, and in some indications I like to use it in dry condition, for example, that eraser flap also on the lingual side. I stick it dryly into the lingual aspects. Then I apply the bone substitute material and I put a drop of saline solution on the membrane. It becomes more flexible, it flips over and stabilizes the graft. This is a quite unique behavior of a membrane when we compare it to other membranes, that we can use it in dry and wet conditions. Also in other indications like the sinus grafting, for example, when we have a perforation of the Schneiderian membrane, or even if we want to install the implants at the same time, sometimes we just want to protect the Schneiderian membrane. So we install a layer of the Jason membrane underneath the Schneiderian membrane.
Right.
We know there's not much regeneration coming from this side. And when we use it in dry condition, we get something like a tent effect. So we get a nice open volume, a void underneath, and we can install the implants after some initial application of bone substitute materials, and then we can fill the gap with some bone substitute material. Also, a nice way to use the membrane in dry condition.
Right.
Moreover, sometimes we like to use it in wet condition too.
Right.
So for example, when we want to adapt it, when it has to be adapted to the surrounding areas,
Right.
just a drop of saline solution will change the
Property.
rigidity of the membrane completely, and then we get a smooth surface and a nice adaptation to the surrounding bone.
Very good. Thank you so much. And with regards to Jason membrane, what are the clinical indications for using it?
I think we can use the Jason membrane for all the normal indications where we use bone substitute materials for smaller grafts. We can use it for the sinus grafting, for the coverage of the facial window, for example. But because we have this prolonged barrier function, we can also use it for larger grafts. In
Right.
combination with other techniques, with blocks, for example, we can use it with bone builder, ring technique. So in indications where we thought in the past that we need autogenous bone to solve this problem, we can now use a combination of a bone substitute material with a long-lasting barrier membrane
Exactly.
that is excluding the soft tissue.
Very
So
good.
this is the biggest advantage, that in addition to the normal indications, we can extend the indication to situations where we have larger grafts, where we use bone substitute materials in combination with some stabilization technique like screws or some additional autogenous bone, where we do sinus grafting and lateral augmentation at the same time, for example. So all these indications can now be solved even without using a non-absorbable membrane, that we use a long-lasting pericardium membrane for the stabilization of the defect,
Right.
and also for exclusion of the soft tissue.
Very nice. So my final question for you is related to what are some things that clinicians can do to handle it? What are some tips and tricks to use the Jason membrane that you could share with your extensive experience?
So whenever we are using this membrane, one trick would be to use it depending on the situation in dry or wet condition. Another aspect might be that we can use the membranes to stabilize the grafts.
Yes.
One very important aspect from my point of view when we talk about membranes is that we are able to fix it, and moreover that not only fixing it will lead to a nice result, that we also can trap the bone substitute material underneath,
Right.
that there's complete immobilization. So the use of pins, for example, has been established within the last 10 years more and more.
Right.
We have now developed some screws even that can be used for the fixation of the membranes, and we have another very positive effect, that when we use screws, we can use the first screws by holding the membrane, that it's not turning, and the last screw, or the opposite side of the graft, is fixed with the screws, but there we are allowing the membrane to tangle a little bit around the screws, so we get even more compression of the bone substitute material.
Gotcha.
Therefore, we need a membrane that is also presenting some tear resistance, for example, which is also a quite nice aspect of the Jason membrane, that we have a very good tear resistance,
Right.
that we can use the membrane for this kind of immobilization.
Very nice.
Then there are other techniques that have been described in the literature, for example. There's a publication from the US, Block, that has presented a technique where you just do a little vertical incision. You perform a tunneling approach just underneath the periosteum, and then a stable membrane is installed underneath the periosteum. Therefore, again, you need a stable membrane, maintaining the space underneath for a short period of time until the membrane gets rehydrated, and then you just place your bone substitute material underneath the membrane. So also for this indication, it's quite nice to have a more rigid, more stable membrane. And another technique that comes from Israel, for example, is a technique that you fold the membrane, you apply some holes on one side, and you trap the bone substitute material in this little pouch.
Right.
So by suturing around with some absorbable sutures, you get a little pillow that can be used for augmentation procedures. It's not a miracle, actually. It's just one way to stabilize the bone substitute material, and you can use some screws or even use some pins to pack this material on the defect, to immobilize the material, and therefore, of course, by facing the non-perforated side towards the soft tissue, you get nice exclusion of the soft tissue, and with the perforation on the bottom towards the bone, you get a focus on the invasion of the blood vessels. So you get the information to build bone from the bottom of the defect, with some more information from the surface, because it's a collagen membrane, the angiogenetic effect, and also in the same line, some immobilization. So this would be something maybe for the future to even more facilitate the application of bone substitute materials in larger augmentation volumes.
Very nice. Thank you very much. On that note, Professor Rothamel, it's been my pleasure to host you today. And on behalf of the over 6,000 employees that make all of this possible, it has been my pleasure to spend the day with you. My name is Dr. Artemis Atkins, and I will join you again tomorrow with more sessions. Until then, auf Wiedersehen from IDS. See you.